One of the issues that I wanted to raise with you was, yesterday you heard this cube, right? I don't like this cube. I don't use this cube, right? What is my problem with it? It is a passive view of healthcare, right? It's taking the horse to water, but I'm not now worried, did the horse drink or not, right? This stops at the water. It doesn't go and look at, nowhere does it say health outcomes. It says it should be accessible, it should be financeable, it should be comprehensive. Did it produce the results? I don't know and I don't care, right? Because the cube is full, I delivered the services that I wanted. The framework I use, everybody has their pet, this is my pet framework. If you see the outcome indicators, right, they have three, which is health status, actual outcome that you got, risk protection, which was again very much part of the previous cube, to what extent are people getting exposed to risk, and responsiveness. And these are all delivered outcomes. And this framework requires you to do it for the average, for the population, and for the bottom 10% of the population. Ask this question, right? And it has some mechanism by which it suggests that you might go, it's called the control knobs framework, because what it says is these are the 5 potential, there could be more, and I use more control knobs in my work, but there could be many more, there could be these as levers to produce the outcome that we need, right? And for example, one difference from a cube type approach to this approach is that a cube would say, we are done if we have built good primary care, and the doctor is sitting in the primary care center, and the nurse is there and all of that. The job of universal health coverage is done. This cube would say, I would say, you have not even begun. Because if the person is not adherent to treatment, if he or she is not taking the pill, if he or she is not doing the 30 minutes of exercise, if he or she continues to experience violence at home, well, you haven't actually offered them the services that they need, because what they need is something that leads to outcomes, not simply a clinic with a doctor. Right? So, and certainly happy to talk about this more if we need. I won't spend time on this. This is an example of how countries have looked at different levers and solved it. One of the issues that, sometimes I also teach at the Lal Bahadur Shastri Academy to IAS officers. What I find very surprising, despite all of the training and everything people get, is that they virtually have no idea what's happening outside India. And they assume that the Indian problem is unique, we have a unique situation, and nobody else has figured this out. And therefore, we have to discover everything on our own from scratch. It turns out actually that's not true. Healthcare is a universal need. Everybody has a problem. India, in terms of health outcome, is ranked 150th in the world, which means we have a lot to learn from many countries, both rich and poor. And there are many lessons. Of course, they have to be adapted to our reality. And even within India, Kerala is very different from Bihar, is very different from Goa, is very different from Telangana. And I'll talk a little bit about those differences. But there is a lot we can learn. And this very last, if you get a copy of the presentation, the way I have organized it, you just have to click that link and it'll open that reference, right? That last one is a film, it's a movie, a short 1-hour movie about these health systems. Very entertaining, very easy to watch. It gives you a sense of how the same problems we are dealing with, the developed countries, this is not a movie about developing countries, how have they solved it? And what is an interesting lesson that we could learn from their work? Yeah. One of the interesting things that I present, and I have a paper on this is called the Preston curve. It's a curve that basically what it shows you is that in this particular graph on the x-axis and y-axis, on the one hand you have expenditure at the bottom. Is there a pointer here? Yeah. This here is the amount of money in dollars that you are spending on healthcare per capita, right? You can see this country here. Can anybody guess which this country is? The US. The United States is a very profligate spender of healthcare. It spends close to $10,000 per capita on healthcare per year. And this is, we use a framework, I don't know how many of you are familiar with this, disability adjusted life years. We are used to life expectancy. The general view now is that human life expectancy, if you want to count full life, it's 85 years. Right? So if somebody has a life expectancy of, say, 70, some country has a life expectancy of 70, you say, well, 15 years of life expectancy is lost. The problem with the life expectancy as a tool is that it doesn't measure disability in terms of mental illness or other disabilities. So this thing came up called disability adjusted life years. Same idea as a life expectancy, but also adding disability to the idea. So here, the lower the number, because this is disability adjusted life years lost, the lower the number, the better it is. And you'll see a whole crowd of developing countries like ours in here. What the Preston curve says is that if you spend a little bit of money extra, you can get a lot of benefit. You see the curve go steeply down. But beyond the point, actually, you could end up wasting money. You know, and I've drawn a single curve. If I had drawn a more complex curve, you'll see the curve actually turns here upwards. Things get worse with more money. US doesn't have very good outcomes because beyond the point, money is not the big issue, but it is a big issue up to a point. And we in India are well below that particular point that might be there. Again, you know, if those of you that are interested in multi-country evidence, this paper of mine, I look at 200 countries, and I look carefully at both rich countries, poor countries, to see. What I was very curious about was not so much the curve. Curve is interesting. What I was interested in is, are there countries at the same level of income as us, or as our states, that have done better than the curve? You see the countries, you know, below the curve? They're all countries that have done much better than they should have done. You know, our neighbor example is Bangladesh, for example. Bangladesh is doing much better than you expected Bangladesh to do because of their overall investments that they have made in multiple things that are going on. I want to quickly get to some 2-3 key concepts that I use in my workshop, and I have state level work as well. One of the issues that I look at, and one of the questions I was asked was, and you know, given my finance background, I used to be a finance person for many years. Does India have enough money to afford universal health coverage, or are we too poor? You know, and many governments will tell you, where is the money for doing this? What I found interesting though is that when I work in Bihar, I was, you know, the local head of Gates Foundation for many years. Bihar and UP are our two big states where we focus. Bihar, which spends about 800 rupees per capita, says we're not spending enough money on healthcare, we don't have enough money as the government. UP in the neighborhood says similar amounts, again they don't have enough money, right? But now if I go to Tamil Nadu, which is about 1,500-1,600 rupees per capita, they say we don't have enough money. I go to Kerala, it's about 2,500 rupees per capita, they say I don't have enough money. If I go to Goa, Delhi, they are spending 5,000 rupees per capita, they say we don't have enough money. I go to Arunachal, they're spending 10,000 rupees per capita, even they say we don't have enough money. Now the reality must be somewhere in between 800 rupees and 10,000 rupees. It can't be that all these states are correct and there is not enough money in India to pay for universal health coverage. Right? So that's something we look at, and what we find very broadly is that at 2018 prices, 2,000 rupees per capita is enough to offer universal health coverage. And there are 13 states in India, or 12 states at that point in 2018, that the government expenditure was already enough to provide universal health coverage for their entire population. Delhi, for example, should not be starting these mohalla clinics, should be offering free health care at every facility of a high quality in its primary care centers, in its secondary care centers, and its hospitals to every single citizen or resident of Delhi. That should be true of Goa, that should be true of Kerala, that should be true of Himachal, and most of the Northeast, for example, except Assam. Because of the grants they get from the center, their expenditure is more than enough to provide universal health coverage to all of them. Of course, the question then comes up is, then why are they not doing it? What is the problem, right? And I'll spend a little bit of time on that. One of the things I do in my work is, if I look at the control knobs that you've seen in that original sheet, there are 5 of them. I add 3 more knobs to it. One is One Health, in which I look at the broad determinants. We talk about climate, we talk about pandemic preparedness, you worry about zoonosis, what is the engagement between animals and humans, where are the diseases coming up, and what does the future look like. The second, I spent some time looking at social determinants of health. Again, I'll talk a little bit about that as an important lever that is available to the state to improve its health outcomes. And third, I look at public health as an issue. In addition to those 5 control knobs, because oftentimes you find that health outcomes, a state is saying, I'm spending enough money, I'm doing all I can, but I'm not getting the health outcomes, right? Because it turns out only about 20-30% of the health outcomes are determined by what you did in your healthcare system. There's a lot of stuff that you would have done that you needed to do outside the healthcare system that you didn't do. And as a result, despite all your best efforts, you're not getting the health outcomes that you want, right? And one of the messages I try to leave with governments is that think of these as free lunches. They don't cost you anything, or they cost you very little. They require some attention on your part, but either you're already spending the money to do this, or you need to add a little bit more to make it happen. You will get a lot of benefit that you would get that might even exceed the benefits from the primary, secondary, and tertiary care work. This is the flying fox. It's a lovely photograph of a very large bat, which is and Hendra virus is a virus that goes to horses, is the virus that is transmitted by this bat. And it has a very nice story. I won't spend time on it just now, as to how this whole issue was dealt with by Queensland in Australia. Because vaccines which were developed, there was only 7% adoption. And you couldn't actually solve the problem via the vaccine because people are simply not taking it. The only reason we have not heard about the Hendra virus so far is a bad reason: extremely high mortality. My understanding is 80% fatality rate. The horse dies, the trainer dies, the owner dies. If they got a vet to treat the horse, the vet also dies. So there's no possibility of transmitting this virus except in the first few hours, in the first few days that you get. It's not like COVID, etc., where you can transmit and you are infectious for a much longer period. And one of the issues in this paper, I have a paper on One Health. When you talk to people and talk about One Health, they'll talk about intersectoral partnerships. They'll say everybody must get together and everybody must discuss and everybody must decide. It turns out that often people they overestimate the benefits of intersectorality, and they underestimate the coordination costs required of simply calling a meeting and everybody showing up. So in this paper, I did this paper at the request of Karnataka government, in which what they wanted to know is if they wanted to organize the state for One Health, how should they be organized? Right. So I looked at multiple countries to see what they have done about it. What I found is all attempts at intersectorality, and I mean all, have failed. Either they set up, so for example, Rwanda set up a commission directly reporting to the president. And everybody said, okay, that's going to work, right? Because it's very high, lots of power. Unfortunately, all the budgets are with line ministries. This commission had no budget. because they had to be allocated to one ministry or the other to actually have a budget. Now, without a budget, what did this poor commission do? Right? When the president came for the meeting, all the senior people came for the meeting. When the president didn't come for the meeting, and the person in charge of the commission was there was no attendance. There were only second, third level people showing up. No impact. A lot of people set up these commissions in health departments to say, okay, the health department will coordinate. But the issue is, it's only the health department then. What about the other departments? They are not interested because it's not within their ministry. Right? And, country after country set up with much fanfare, much debate, much support from the community, much discussion, but no impact. Right? What I recommend, in fact, is duplication. It sounds inefficient because everybody is creating their own little piece, but there's some logic I offer as to why costs of coordination should not be underestimated. Sometimes, I don't know how many of you work in large companies. I've had the good fortune, misfortune of working in very large companies. You would imagine that HR departments of large companies would be more flexible because HR has more flexibility, more resources in large companies compared to startups. Exactly the opposite happens. In startups, a lot more flexibility of policy, etc. is there. The minute the organization becomes large, HR departments organizes for its convenience, not for the convenience of employees. And you start getting a lot more bureaucracy because centralization, while it produces efficiency, produces a lot of cost as well. Social determinants, I'm sure you all know about what the social determinants are. Just to give you an example of a social determinant that is, sometimes when we think about social determinants, we think, oh yeah, these are these abstract ideas of gender balance and equality, and that's what we mean by social determinants. That's not what I mean by social determinants. That's not what the message I want to give governments. I want to talk to them about things they can do here and now, and that are implementable right away, and can have a big impact on this. Those of you that are from Bombay, you will recognize this Bombay Development Department chawls, BDD chawls, that are in the central Mumbai area. These were built in 1926. Right? You'll see, and from this angle it's less visible, but unfortunately this is the best picture I could find. If you see this gap between the two chawls, right, and you draw an angle from here to here, to the top, from the bottom to the top, right? Think of that as an angle. That angle is 63.5 degrees. Right? This rule was put into the Bombay Building Code in 1896 after the bubonic plague. And those of you that are interested, there's a lovely histories of how bubonic plague was dealt with. We did not know, at that point, germ theory was not so clear. People did not know why these diseases arose. But there was a sense, the word that was used was miasma, a sense of something in the air. Because there was something in the air, you needed the air to circulate. Which is why this angle was made possible so that there was distance and there was light that would come in properly. Right? In 2007, Bombay passed the Slum Rehabilitation Act and started to build what they call the SRA buildings. Right? Now look at these SRA buildings, look at the gap between them. In fact, I have I thought I had a much nicer picture, close-up picture there. I have it in the paper, I have a paper on this. But you can make out there is no gap between the two. In fact, if you look at the picture of, Lalubhai compound, Natwar compound, there are many of these, buildings in Sivri and other parts of Mumbai. They are like dirty canals. It's all trash in there. You can't even walk through them. A project was done by a group of architects, pulmonologists, etc., coming together to look at tuberculosis in these buildings. 40%, we are all very focused on treatment of tuberculosis. That's very important. But we forget that 40% of Indians have latent tuberculosis. right? And if these start to convert to active TB, no matter what you do on the treatment side, we'll get overwhelmed. Right? They found that the first floor of these buildings had 6 or 7 times more TB than the 10th floor of the same building. Because as you go up higher, naturally you get a little bit more sun and air, the bottom you don't. And just to give you a sense of what is the recommendation then, right? That the recommendation to the city is, if you want to deal with tuberculosis, a fairly simple solution for you is to either bring back that rule, right? Or the architects were clever. They realized that people will not, because builders will say, I'm making less money. So how will this work? They suggested twisting the buildings. So you don't build buildings next to each other, twist them so that only the edges are close to each other. The face of the building is open. Also, and you don't see the design here, donut designs that have a hole in the middle, are much better in terms of air and light than solid designs. Now, this is something cities can implement tomorrow. There is no extra money they have to spend. There is no cost to them. In fact, the architects show there's no cost even to the builder. It's just slightly better thinking that is helpful to make this happen. Bombay Development Department Charles, no tuberculosis. Because of this enormous distance between buildings. They have many other problems. I'm not telling you that's a perfect place to live, but tuberculosis is not there. And I argue that these are all free lunches, right? On housing, on infrastructure, transportation, a number of areas. I'm happy to spend more time on any of these. Unfortunately, we don't have too much time, so I'm just going to go on ahead, because I want to give you a sense of how does it all come together at a state level. These are essential public services. I'm sure, again, something that you know about quite a lot. One of the benefits India has, which other poor countries don't have, is we have geostationary satellites, right? So this is a field called landscape epidemiology, in which what you do is you look at the Earth, you look at the country from satellite, and you're asking questions about where are your bat populations, where are stagnant pools of water. So there's very nice work, for example, now malaria is not a big problem now, but it used to be a big problem. And what they found is where farmers are cultivating fields in solid patterns, meaning one field after one field after one field, malaria levels are much higher than if farmers are cultivating in a checkerboard pattern, in which one field blank, one field blank, one field blank. So instead of leaving, farmers will leave some fields fallow for regenerating the soil, but instead of leaving fields fallow on just one side and cultivating fully one side, intersperse the two. The larva of the malaria, the mosquito, the Anopheles mosquito, doesn't grow as much in size, and therefore its flight distance gets much more restricted with this simple change, something that a panchayat, for example, can implement. And this is an example of something similar that you saw in New York. This is a photograph of New York from satellite. Public mental health, is another area. There's a big session coming up on mental health, so I'm not going to spend time on it. But a lot of the work that at least I have seen on mental health, and there's a lot of literature that I have not seen, so I could be missing a lot. Me and my co-author, we didn't see a lot of work on what we call prevention. We see a lot of work once somebody is sick, how to give them the treatment that they need. Our argument is there's a lot that can be done much earlier and can have a much longer impact with much lower risks of harm associated with it. And we have a new paper on this. So I want to spend a little bit of time on the state health systems to give you a sense of what I've been working in multiple states with similar ideas. This is an interesting map of India, which I discovered that not perhaps not as familiar to everybody as I had imagined. This is a map of C-section rates. Right? Roughly speaking, we know that 1 in 5, 1 in 6 women will need surgical intervention. So you should see in a good health system, C-section rates, certainly not lower than 15%. Some people have argued not less than 20% at a population level, at a district level. If you start to cross 20%, that's too much. 25%, it's too much. If you are below 10%, perhaps that's too little. Now, just using that data, if you see the red, which is our central belt, Bihar, UP, Rajasthan, Chhattisgarh, MP, Jharkhand, those numbers are abysmally low. Right? There's simply no hospital capacity there. One of the phrases you heard yesterday, which I know some of you liked a lot, so I'm going to be very unpopular when I say this, UHC through PHC is a very nice slogan, but it's not policy. It's not good policy. Right? My recommendation to Chhattisgarh government, build hospitals. You don't have hospitals. Right? Primary care, there are many providers out there. They're not all of the same quality that you want, but Jholawalas can offer primary care. They cannot offer C-sections. Without C-sections, you're not going to cut maternal mortality. You're not going to cut infant mortality. And of course, we have a unique problem in the south where you see, the Telangana-Andhra belt. Those numbers have just crossed astronomical numbers, right? And the challenge with this graph is, this is of course a total C-section rate. If I drew this for you for the public sector, it is the same. The south, the public sector is doing as many C-sections, as the private sector. In several districts, it does more than the private sector is able to do because it can afford the doctors, it can afford everybody. The private sector may not have enough money to get everybody that they need to do this. And this is something that may be familiar to you, just to show you that, and each dot is a state. The dot on the right is Telangana. The dots here are more Bihar, UP, is that as C-section rates go up to 20%, which is roughly Maharashtra, maternal mortality drops, and then it flattens to slightly rises. Of course, I drew a single curve, so it looks like it falls always. But, unfortunately, there's not enough data for me to have drawn two curves with any test of significance. But, this is roughly what the message from here is, right? Similar stories on access to surgeries. Primary care, just to give you a sense of what is going on in primary care. There's a very nice analysis that was done 2015-16 data. I haven't seen a similar analysis with 1920 data, right? And I don't know if this is visible to you or not, but this is Bihar. This is the number of women who were pregnant, who got comprehensive maternal and child health care as defined by current government policy. 4 antenatal checkups, IFA tablets, all of the standard stuff. 3.3%. That is only 3.3% of the women got the full maternal and child health care that they were required to get in 24-15-16. In fact, very few states will cross 50% in this number, right? And, in some ways, one could argue, we are talking about NCD, we are talking about diabetes, we are talking about hypertension, we are talking about mental health. We have not delivered the basics, right? And whenever anybody tells me, now we will add mental health also to this person's responsibility, I say, oh my God, then that number is going to fall even further, right? They're going to do nothing. Because now they'll be running helter-skelter, trying to do 25 different things without having solved even the basic problem. It's not, one could say, oh, well, they have too much work. But just to give you a sense of the too much work paradigm, right? A UK general practitioner single person serves 1,700 patients on average for all diseases. The ASHA is assigned 500 women only for one condition. She clearly has not enough work. But she had not enough time as well. She's not fully paid. She's not required to work full time. Right? So there are a number of other constraints that you've imposed in her that are preventing her from doing what she needs to do. And she receives hardly any training, sometimes 2 days, sometimes 3 days. Just quick drive through the states, and I will stop. Kerala, what is going on? I mentioned this a little bit here. We have this belief that Kerala is doing very well. It may have been doing very well some years ago when infectious disease was the only thing we were worried about. Now, unfortunately, what has happened is the public sector looks like it's de facto exiting healthcare. In terms of delivery of babies, the country does 70% of babies are delivered by the public sector, except in Kerala, where the number is, falling every year. By 2030, 35, that number could be 0 in terms of how many babies the public sector is delivering. C-sections, massive abuse in Kerala of the C-sections by the public sector. There was a Foxy report on why is the Kerala maternal mortality. So the problem with Kerala is we always compare it with Bihar and we say, oh my God, it's doing so well. Right? No. Kerala was doing better than Bihar in 1900 also. Right? This is not something to be proud about. Right? Kerala should be compared with a developed country, a modern, let's compare it with, say, Japan. Japan has a C-section rate of 14% and a maternal mortality of 1 per 100,000. Kerala has a C-section rate of 60% and a maternal mortality 20 times higher than Japan. Right? And there was a report that was done by Foxy as to why is this the case. It turns out post-operative sepsis. You gave a woman a C-section she did not need, and then she died because you didn't have good infection control inside your hospitals. Right? And there is many other harms that come from the C-section. Very high NCD burden. I mentioned yesterday, there is a concern that in districts like Pathanamthitta, you might start seeing an epidemic of amputations starting to emerge. Every home an amputee. Whenever I present this data, people say, oh, it's a lifestyle problem. Yes, it is a lifestyle problem where the disease originated. Diabetes and hypertension are some of the easiest to diagnose and treat diseases on the planet. Right? Very quick tests are able to tell you what you're supposed to do. Very quick treatment strategies are available to you. If you're not able to control the disease burden, it means you don't have a good treatment strategy in place. You don't have good primary care. Right? And there is work, very nice work by Nandaraj and Nambiar, which looked at government's own HMIS data. And you might argue HMIS data is always inflated. They're always showing more patients, always showing. They looked at that data. And they find most PHCs and sub-centers in Kerala have maybe 1 patient a week, 2 patients a week, 1 patient a day. They're not busy. It's not that crowded PHC we have in mind. That may be true of some, centrally located PHCs. It's not true of most PHCs. And at least our research shows, and not everybody agrees with our research, let me be the first to admit that, is that Kerala is spending enough money to offer universal health coverage. If it stopped wasting money on C-sections, if it has no automation. One thing that we discovered to our horror during COVID, we were quite closely involved with the Kerala government. The Kerala government health system has no automation at all. So you go to a PHC in Kerala, right outside a hospital, and then you go to the hospital right next to the PHC. They don't know who you are. They have no data about you. If you happen to carry something with you, they will start again from scratch using that data. So clearly, there is a lot that they can do. Chhattisgarh, of course, has a number of other issues, but one of the big concerns here is, inadequate emergency care. They simply don't have the hospital base that they need to make things work. There are multiple districts where C-section rates are less than 5%, total C-section rates. I mean, neither the private sector is there, nor the public sector is there. In fact, if you look at the data, the public sector is much more urban biased in these states, If there is a service being made available of C-sections, it is the rural bias of the private sector that is giving you that service. If you took out the private sector from these poor states, the service levels would just collapse because the government is unable to staff or unwilling to staff rural hospitals. Urban hospitals, they have lots. Odisha, another state that I did something similar with. One of the challenges you find in Odisha is that there are actually multiple health systems within the same. For those of you that are from Odisha will recognize this. Actually, there are three broad health systems. There is the eastern coastal belt, there is the western industrial belt, and then there is a central tribal belt. Central tribal belt looks like Bihar. The western coastal belt looks like Kerala. The industrial belt looks like Maharashtra. Right? Very different health systems, very different healthcare realities, very different responses that are needed for the state. In the paper that we argue for the health system for the coast, we say stop building more hospitals. You really need to start thinking about social determinants, start thinking about your urbanization, how you're building your cities. By building more care, you're not going to solve the problem of this massive burden of diabetes that you're getting hit with. Whereas the central belt, hospitals are essential. You have not built the hospitals that you need. You can't afford to continue to just do primary care and think that health of the population will improve. Telangana is a state that I spent more time on in this particular presentation. Again, what you find is that in Telangana, the central belt of Telangana, the district we are in today, as well as other districts around, are the ones that have the biggest challenges that you see on the ground. And on the northern and the southern districts, Telangana has a terrific health system. It has very good secondary care, very good hospital care. In fact, what was surprising to me was a state that has such good hospital care, why did it launch an insurance program that allowed people to go to even more hospital care? They did not need it. They didn't need it then, they don't need it now. What they need is much better primary care, much better engagement with the communities on the ground, much better social determinants of health, which they have not bothered to invest. And they have taken 30% of their health budget and put it into this insurance scheme. For many states, but certainly for the state of Telangana. It is one of the largest generators of methane, of greenhouse gases. It has very low productivity. In fact, if you made the rice productivity of Telangana comparable to the best in the world, we could give up more than half the land and have the same rice production that we have today. Right? And they need to think about what to do about it. They do need to worry about their animal populations, particularly bat populations, in the northern forested areas of Telangana. Because if they start to see bat populations emerge, if you go to Raipur, for example, right, you'll see small bat populations under house, my understanding, that beautiful flying fox that I showed you, right, they live in groups of 100,000. If you see these small populations, it means these populations are under stress, which means they're shedding a lot more viruses than they should be, right? You need to think about what your overall strategy is to figure out what to do with it. Number of interventions so in any paper, I've circulated the Telangana paper to you, and if you don't have it, I'm happy to do so again. I have an Odisha paper as well. I'm working on a new one for Bihar, each one of them for those governments. What I try to do is assemble the ideas across all the primary, secondary, tertiary, social determinants, One Health, public health, into one place so that the government has the blueprint of what they might do to improve health outcomes in their specific state. I'm doing a new project with IIT Mandi on doing the same thing at a district level. so that in every district we can go to the government and give them a very precise plan as to what they might want to do. So I will stop here. Thank you very much. This is a schematic that I have towards the end of the paper as to what a good health system would look like. And some of my work includes involving faith healers, pharmacies, and family members in the design of a high-quality health system to make things happen. Sorry, yes.
Thank you, Dr. Nachiket Mor. Can we quickly take 2-3 questions?
Japan is having only 15% of cesarean section rate. WHO also says that how to reduce the cesarean section rate, and all over the world, what are the strategies given by the guidelines for reducing cesarean section rate. And in further, if we can dig the data into emergency cesarean section rate and elective cesarean section rate, can we give some kind of insight whether it is unnecessary cesarean section done in this particular population or district or state, which can be getting a good view out of that? Is it possible?
No. So the dominant share of C-sections is low-risk children. Children who did not need it. In fact, even in states where the C-section rate is low, Chhattisgarh, Bihar, bulk of the C-sections are elective. What happened to the women that needed emergency care? They died. Right? They just didn't get it. I went to a district hospital in Jahanabad when I was at Gates Foundation. The room is full of babies that, there's this idea called the sick and newborn care unit. My impression of I'm not a doctor. I had gone to the Amrita Institute some years ago to see their sick and newborn care. 800-gram babies, 1,200-gram babies on respirators, fighting for their life. One pediatrician running around saying, they will all grow up well, sir, don't worry about these children, we know how to rescue them, etc. I go to this SNCU, 2.5 kilo, 3 kilo babies. I asked the pediatrician, sir, this is not what I'm used to seeing. These look like normal babies. He said, sir, they indeed are. We had no C-section capability. The delivery was delayed. We thought baby would come out on their own, didn't come out. Mother died, baby asphyxiated. Somehow we got the baby into this SNCU. It's almost brain dead. And this is the bulk of the babies. And the family is standing outside, eagerly waiting that, well, we've lost the mother, but we will have some memory of her in the form of this beautiful child. Pediatrician is telling me, sir, I'm hoping that it's finished here only. Because the child will be a liability to them even if the child survives and cause more grief to them. This is the unfortunate reality. So who are getting those 2%, 3% C-sections? Those who can afford it and those who can pay for it.
So we can understand that who needs a cesarean section, they are not getting. Who does not need a cesarean section?
No, in Kerala I would say those who need it are getting it definitely. Because there is a statistic on very poor people also, what are they getting? They are getting good C-sections. And in fact, that's what the point I was making yesterday. They're getting the right level of C-sections. No electives are being given to them. It's the rich that are getting hurt because they can afford it.
के रोल बहुत अच्छा रहता है, सिविल सोसाइटी और सरकारें जो है ये मिलके अच्छा करती है, लेकिन मेरे ख्याल में ये खाली लिखित है सर, ये बाकी सरकार और सिविल सोसाइटी के बीच के अंदर जो गैप है वो उसके लिए कोई ऐसा सॉलिड स्ट्रेटजी नहीं बनी है अभी तक मेरे ख्याल में। कई हर एक स्टेट की जो कि शामिल होते हुए जो है मिलके जो है ऐसे इशूज़ के ऊपर काम करें, तो इसके ऊपर यदि कोई आपका कुछ ऐसा है तो वो हमको अवगत करा दीजिए। थैंक यू।
कई ऐसे प्रोग्राम्स हैं, हेल्थ एंड वेलनेस सेंटर आप देख लीजिए, उसमें मैं खुद इन्वॉल्व था और एक अच्छी सिविल सोसाइटी ऑर्गेनाइजेशन है छत्तीसगढ़ में, जन स्वास्थ्य सहयोग। ये मॉडल उनका और थोड़ा काम हम लोगों ने किया था तमिलनाडु में, उसका सम्मिश्रण करके ये मॉडल बना है। और योगेश जैन जैसे एक्सपीरियंस डॉक्टर्स ने लिखा है पूरा, ये पूरा डिज़ाइन, पूरा थिंकिंग। आज 1,70,000 हेल्थ एंड वेलनेस सेंटर्स हैं कंट्री में सर, और ये एनजीओ और गवर्नमेंट कोलैबोरेशन की मिसाल है।
डॉक्टर्स को प्रिपेयर करते हैं, देयर इज ऑल्सो शॉर्टेज ऑफ डॉक्टर टू टीच देम एक्चुअली. सर क्वालिटी, एक तो शॉर्टेज ऑफ डॉक्टर है, एंड जो डॉक्टर निकलते हैं ड्यू टू लैक ऑफ trained teacher in the medical colleges, again quality hampers. So what is your insight to it and how to deal with this?
ईरान की मिसाल मैंने कल दी थी. उनका एनसीडी कंट्रोल रेट दुनिया में सबसे अच्छा माना जाता है. कहाँ ज़्यादा अच्छा है? रूरल एरियाज में. क्योंकि वहाँ डॉक्टर का इशू क्या है? डॉक्टर प्रिस्क्रिप्शन देके आपको बोलता है आप करो, ट्रीटमेंट का एडहेरेंस, दवाई लो जो भी है. अनफॉर्चुनेटली ट्रीटमेंट एडहेरेंस एकदम लो है. मतलब लोग समझते हैं आधे लोग लेते हैं आधे नहीं लेते हैं. नहीं, 20% लेते हैं, 80% नहीं लेते हैं दवाई लेने के बाद भी. ईरान ने क्या किया? जो बहरबाज हैं, जो हेल्थ वर्कर है, उसका काम ये था कि दवाई जो देनी है वो दवाई ये व्यक्ति ले और समय पर ले. ट्रीटमेंट मैडम उतना मुश्किल नहीं है. डायबिटीज़, अगर आपका ब्लड शुगर 200 से ज़्यादा है, मैं डॉक्टर नहीं हूँ लेकिन मुझे भी मालूम है 500 मिलीग्राम मेटफॉर्मिन एक बार शुरू कर दो, महीने भर में इम्पैक्ट आना चाहिए. हाइपरटेंशन में भी समथिंग सिमिलर. 80-90% ऑफ कंडीशंस ऐसे ही हैं. 10% जो रिफ्रैक्टरी हैं. रिफ्रैक्टरी कंडीशंस के लिए हमें MBBS नहीं, स्पेशलिस्ट चाहिए. और वो वाया टेलीमेडिसिन, ई संजीवनी के माध्यम से मिल सकता है. हमें उनको यहाँ लाने की ज़रूरत नहीं है. तो एक तरह से मैं समझूंगा मैडम कि उतनी कोई मुश्किल नहीं है. लेकिन हमने क्या किया है, थाईलैंड ने 1995 में जो आशा थी, आज उस आशा की कैपेबिलिटी इतनी बढ़ा दी है कि वो ऑन्कोलॉजी नर्स है. हमारी आशा ही है. उसको ना तो ट्रेनिंग दे रहे हैं, ना करियर दे रहे हैं, ना सर्टिफिकेशन दे रहे हैं. पैसा तो दे ही नहीं रहे, लेकिन और कुछ भी नहीं दे रहे. और कई हमारे जो हेल्थ वर्कर्स हैं, वॉलंटियर्स हैं, उनको भी ना तो हम सर्टिफिकेशन देते हैं ना ग्रोथ करवाते हैं. वो ही काम कर रहे हैं. मैं 20 साल बाद भी जाता हूँ किसी NGO से मिलने, उसी व्यक्ति को मिलता हूँ, वो वही काम कर रही है. क्योंकि हम लोग भरोसा नहीं कर पा रहे हैं उसके ऊपर. हमें प्रोटोकॉल्स नहीं दे रहे हैं. प्रोटोकॉल्स पार्टली हम उनको नहीं दे रहे हैं क्योंकि हमारी खुद की प्रैक्टिस एज डॉक्टर्स प्रोटोकॉल ड्रिवन नहीं है. हमें खुद को नहीं मालूम है प्रोटोकॉल क्या है. इसीलिए ऑन ग्राउंड प्रोटोकॉल हम दे नहीं पा रहे हैं. तो मेरी समझ है मैडम, अगर दुनिया के एग्जाम्पल्स को देखें तो डॉक्टर की कमी डेफिनेटिव नहीं है. और केरल का आप देख ही रहे हैं मिसाल. डॉक्टर की कोई कमी नहीं है. हर PHC में, सब सेंटर में बैठा हुआ है. PHC में तो बैठा हुआ है ही. नर्सेज हैं, रिक्रूटमेंट उतना गैप नहीं है उनका.
हम जो फील्ड में अभी काम कर रहे हैं तो बहुत बार मेडिसिन स्टॉक आउट हो जाता है. जैसे TB का मेडिसिन 4 महीने नहीं है, HIV का मेडिसिन बहुत दिन नहीं है. रिक्रूटमेंट गैप जो NCs और आशाज है उनका काफ़ी लो है. तो इसकी वजह से वो पूरा जो साइकिल एक TB पेशेंट का या HIV पेशेंट का पूरा हिल जाता है और अननेसेसरी उसको फिर सेकंड लाइन या थर्ड लाइन पे जाना पड़ता है मेडिसिन के लिए, TB या HIV.
यूपी में देख लीजिए, MP में देख लीजिए, सरकार के पास दवाई नहीं है लेकिन बगल में प्राइवेट फार्मेसी है, उसके पास भरपूर दवाई. वो उसने कहाँ से लाई? उसी के पास भी तो वही सप्लाई चेन है. और मैं कई बार ये कहता हूँ मैडम कि जो आदमी, वो हिंदी में कहावत है ना कि जो आदमी सोया हुआ नहीं है उसको जगा नहीं सकते. आपको करना ही नहीं है तो आप 10 प्रॉब्लम्स निकालेंगे. नहीं तो अगर आपको सोल्यूशन निकालना है तो टेक्नोलॉजी भी है, सप्लाई चेन भी है. कोविड में हम लोग जो इन्वॉल्व थे रिलीफ सप्लाईज में, प्राइवेट डिलीवरी एजेंसीज दूर सुदूर गांव में सब सेंटर पे जाके डिलीवर कर रही थी मशीन्स. कैसे? वही सड़कें हैं जो बाकी सब लोगों के पास भी है, उन्हीं सड़कों पर ये डिलीवरी कर रहे थे, गारंटीड डिलीवरी. आज दवाई आप फार्मेसी पे चले जाइए, जीनो पे चले जाइए, इंटरनेट बेस्ड हैं. 99% इंडियन पिन कोड्स में ये 24 आवर्स में डिलीवर कर देगी. कोई भी दवाई आप गिन लीजिए. तो ऐसा नहीं है कि हमारे पास हल नहीं है, सोल्यूशन नहीं है. साउथ सूडान में हम होते तो मैं समझ पाता कि भाई वहाँ जो सिचुएशन है बहुत डिफ़िकल्ट है. इंडिया में नहीं है. अब यही हमें बैठ के डिस्कस करना है. स्टेट अथॉरिटीज से कि सर प्रॉब्लम क्या है, आप थोड़ा समझाइए हमें कि ये सब इश्यूज अभी तक क्यों चल रही हैं। मैं कई सरकारों को कहता हूं कि पैसा मत दीजिए मोर, पैसा बहुत है, जो है उसको करिए ठीक से, और आप कर सकते हैं। नहीं करना चाहते उसका हम हल ढूंढते हैं मिलके, क्यों नहीं करना चाहते? क्योंकि कोई कहते हैं वोट नहीं मिलेंगे, भाई पैसा फेंकने से तो वोट मिलेगा नहीं, पक्का नहीं मिलेगा। अगर दवाई एमॉक्सिसिलिन नहीं है आपके पास, छोड़िए एडवांस्ड एंटीबायोटिक्स आपके क्लिनिक्स में, तो 2 गाली और मिलेगी वोटर से। तो ठीक है, नए अस्पताल बनाने से, प्राइमरी केयर बनाने से आपको वोट नहीं मिल रहा है, आप जीत नहीं जाओगे इलेक्शन, लेकिन अगर दवाइयाँ नहीं रहेगी तो हार जरूर जाओगे।
When we think about addressing social determinants of health, probably intersectoral action, needs to be taken. So, can you share your thoughts on how to address this dilemma between cost coordination and, benefits of intersectoral action?
My view is that yes, to evolve the solution, we may need intersectoral conversation, but that researchers can do, NGOs can do. Instead of calling everybody in a meeting, an NGO can meet each person in their own cabin and evolve the solution. But the actual solution, I mentioned the Bombay Development Department CHOLS. It's clearly a function of the urban planning group. I don't need health department involved, I don't need anybody involved. My only request to the health department is, make a request to your neighbor, the minister or the MLA or the councillor responsible, कि सर उसका भी ध्यान रखिए, क्योंकि आपके कारण हमारा टीबी का बर्डन बढ़ रहा है। It's a free lunch, आपकी जेब से नहीं जा रहा है। So, intersectorality often results in no action. That is the fear, at least in the One Health perspective. And there is a, if you read the paper, you'll get a sense of what it is. But it turns out that there is separability, what we call in mathematics separating hyperplanes, where there is separability. If I look at, for example, rickettsial diseases that are, they are a lot more urban in nature. If I look at bacterial diseases, they're a lot more agricultural in nature. If I look at viral diseases, the spread of viruses has got a lot to do with commerce and trade and airline and trains. They all have health departments. All these divisions have health departments. Instead of saying health ministry will be responsible for all those issues, can we say urban is responsible for rickettsial, agriculture is responsible for bacterial, transportation is responsible for viral? Now you might say, well, then we might leave out, वहाँ उसका intersection miss हो जाएगा, उसका intersection miss हो जाएगा. Let health ministry play a coordinating role, but not a power role. Nobody reports to them. They have no budget. They are simply exchanging information. And there is a unit, the way the Indian system is organized, under the district collector, everything comes together again. There are only 2 points of convergence in India, the Prime Minister and the district collector. These are the 2 places where everything comes together. District collectors are quite happy to bridge the gap that they see across departments. And they have the power, they have the budget.
Thank you.
Thank you so much, Mr. Mehta. For the first time in my life, I think I understood climate change. Your simple way of explanation made me really feel that now I know what I have read, heard, and what I need to do. My grandchildren always told me that, Grandma, your cattle in India are causing climate change. Now I understood what they are talking. So thank you very much. I really feel I know now climate change.
How should we design a community, or what has climate got to do with my immediate, let me say, adolescent age issues and stuff. But I think increasingly I am very convinced, I'm a practitioner, I'm a physician, working in the urban poor sector. I'm very, very convinced that that is what has to be tackled, just like Mr. Nachiket Mor said. Sometimes the solutions are not just per se, you just sort of bulldoze your way more and more, ram yourself into that same direction, rather than probably creatively think like the building 63.5 degree rule, right? So that is one remark. So these two sort of are very well juxtaposed sessions to, I think, bring it into our perspective, the health sector team's perspective, that sometimes we keep wondering, why are we not solving certain things? You know, like I was saying, there is a vector survey that happens, but unless and until we solve the solid waste coming into the drains, no matter whatever Asha worker does as a vector survey, we are going to fail. So that is one remark. The second is a little bit more to do with exclusively to the climate change. There is this increasing concept of Miyawaki forest as a carbon sink. Would you see it, because why I'm asking is urbanization is a reality, right? I mean, humans have to live the way we live, or let's say even tweak it a little, but we still have to. Do you see Miyawaki forests gaining traction, especially for a dense populated country like India?